Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video is missed by anybody.
All right. So like I said, at this class, I'm going to make your fundas absolutely clear regarding your cervical cancer. It's not that lengthy a topic as it is given in your multiple books. And to read from a book, it's very difficult to pick and choose what's actually important for your examination. And by the time you start finishing off the entire book, you are at a loss of, sentences or points which you have to put down on your examination. So tonight I'm going to be making those fundas absolutely clear before you. The topics which are important for you, the way they should be read, the way it should be remembered, what you have to supposed to write down in the examination, those point shooters, and they're all made from a recent current guideline. And let me tell you, Figo update, whenever it comes, you should always keep an eye on it, because Figo trumps every other thing about cancer, unless of course it's coming from another very important superior body above Figo, but Figo looks like or is supposed to be the last word when it comes to cancer. So I've taken the one which is recent for cervical cancer, and this is on Figo, and made my notes based on that. And from there, I'm going to take you through this entire journey of cervical carcinoma. Remember that I already covered the pre-invasive lesions of the cervix in my last class, which is pretty much distinctly clear for you people what exactly to read, how to read, what to read, and how much is supposed to be asked in the exam and what you're supposed to answer. All right. Okay, somebody is asking Ashish that where and how to join. Send the link. Okay, so just help these people. The number is there in the chat. So just help these people. Jitu, if you're there, can you please help these people in the chat? Now, I begin with cervical cancer. Keeping in mind that we've already covered the aspect of pre-invasive lesions of the cervix, and now we're going a step ahead. Remember that up till now, suppose there was a micro-invasive disease, patient was coming to you with complaint of irregular bleeding, spotting PV, postcoital bleeding, and that raised suspicion that, oh my god, this patient could be a case of pre-invasive lesions of the cervix. You went ahead and did an HPV screening. Like I told you, is the new latest protocol that you go ahead with HPV, came out positive. That made you do a cytology. Cytology was also abnormal. Dyskaryosis, moderate, mild, severe dyskaryosis, you went ahead and did a colposcopy, and then finally CIN came. Then I told you everything regarding that protocol. What are you supposed to do? How are you supposed to, manage CIN1, CIN2? Suppose colposcopy doesn't show anything, then what are you supposed to do? How to follow up such patients? So that part, huge part, is over in the last class, right? So now we're talking about those cases which are frank carcinomas. We're above and beyond the case of pre-invasive lesions. All right, we're not sticking on to cervical, CIN1, 2. We are now having frank, full-blown cervical carcinomas, and you're going to find a huge burden of this in countries like ours, okay, where you do not have such strict screening protocols, you do not have a huge amount of vaccination, you have a lot of ignorant and let's say, that crowd which is not very well aware and alert about these newer diagnostic modalities and who are not at all compliant with their follow-ups, right? So finally, these patients end up with the frank, full-blown carcinoma, and this is what we're going to deal in the class tonight, right? Now, starting with the first things, this happens to be the burden. Look at the burden. It's the fourth most common after breast, colorectal, and lung, and majority of new cases and deaths, they occur in our low and middle income countries like ours, like I said. So here it becomes the third most common cancer in the women. And we know that the cases of cervical carcinoma, they originate from the ectoendocervical mucosa in the transformation zone. And how important is the transformation zone? We got to know it in the last class. Remember? I told you 3 types, are there: type 1, type 2, type 3. And then I told you how to manage these type 1, type 2, type 3 when you take biopsies. How do you go about it? How do you go about it if there are positive margins which are left behind? Then what do you do? Everything has been included in the last class. So, and the class is still there on my channel. So please go ahead and see that class, because then I'll be removing it after this class. Now, this is a little bit of those slides which you've already studied before. So early detection, prevention of cervical cancer is the way to go, okay? Then, this going ahead with pap smears or your VIA, VILI, so these are very important tools in getting to know the pre-invasive lesions, right? And the vaccination to young girls, HPV screening in the older females, and then going ahead with the triology of both HPV, pap smear, and colposcopy whenever it's needed. All these help to reduce the burden of cervical carcinoma. And then a few, what kind of, if at all, you do have a cervical carcinoma, it mostly belongs to the squamous cell carcinoma type. Some are HPV associated, some are not associated with HPV. All right. Then you have another burden of another kind of, see, whenever I talk about cervical carcinoma, mostly I think about squamous cell carcinoma because 80% are actually squamous cell carcinomas. But there is also another variety of adenocarcinomas, right? So they follow a different pattern, they go in a different direction. But mostly in this discussion tonight, we will not be dealing a lot with adenocarcinoma. But remember, I spoke about CGN to you. They are actually one step further of those CGNs. That is, what did I say? Glandular epithelial neoplasia. So here you have one step ahead of that adenocarcinoma. Now they have become into full-blown carcinomas. Now, tell me one thing, guys. How do you go ahead and diagnose that it is not pre-invasive lesion? It is actually cervical carcinoma. It has breached the basement membrane. It has gone inside, and now it is no more CIN. There is no more just neoplasia associated. It's gone inside. And now we call it frank cervical carcinoma. You get to know it only and only through biopsy, correct? So what you do is when you see certain changes, if you're seeing a polypoidal growth, all right, if you're seeing a macroscopic growth on the vagina or on the cervix, you're taking a punch biopsy and you're going ahead and giving it for biopsy to understand what is it actually, and it comes out to be squamous cell carcinoma, my dear. But if you suppose you're not seeing a punched out lesion, and in pap smear, if you had taken before, it was like it reported us, cells which are highly metaplastic, dysplasia is there, severe dysplastic changes are seen, suggestive of squamous cell carcinoma. You go ahead and take a biopsy. I'm talking in terms of punch biopsy or a loop biopsy or a cone biopsy, and there you find what is the level of this carcinoma, right? Suppose cytology report tells you that this is, the changes are suggestive of squamous cell carcinoma, or cells of their likelihood of squamous cell carcinoma is there. You go ahead, and this was cytology. Okay, there's a difference. Cytology, that means they're taking islands of cells. Okay, interspersed islands of cells are being studied. One step better is a histopathology, where a whole chunk of tissue you are studying, correct? And this whole chunk of tissue that you are studying, you are trying to see that entire zone of a tissue has come in it or not, correct? And from there, so many things emanate. What is the depth of invasion? How much is the, dysplastic changes, and the surety that it was actually cervical cell carcinoma. Now, talking about the diagnostic evaluation of cervical cell carcinoma, you have this so you have these stages now. All right, so stages of diagnosis of stages 1A and 1-2. Can you imagine? I'll go on the stages to you as well. I'll describe what exactly is the staging of cervical carcinoma like. But the initial few stages in which you cannot see a macroscopic lesion, like I said before, how will you get to know that there's what kind of invasion is there, and whether it is stage 1A1 or stage 1A2, because you do not make out whether it is 3 millimeters or 5 millimeters, because it's microscopic. So what do? You get to understand that there are these stages only with the help of biopsy specimens. So it could be a cone biopsy, it could be leap, it could be a cold knife conization. So it could be a cone made from anything. It could be a cone made from cold knife, it could be a cone made from cryo, or mostly it is from the cautery, right? Now, obviously, apart from that, you have the trachelectomy specimen, you have the hysterectomy specimen. These are also ways in which you can get the biopsy, and you can subject it to the histopathology, and you get to know what is the depth of invasion, or what is the extent of the lesion. So I'm right now focusing on how do you diagnose that it's a cervical carcinoma. So I told you one way, sometimes it so happens that it comes in PAPS, cytology report. You have to back it up with a histopathology. And how do you take the histopathology? If you can see the tumor, you take punch biopsies. If you cannot see the tumor, you go ahead with leap. Okay, a proper leap encompassing both the lips of the cervix. That's always the best way to go. So if it's a microinvasive disease, you go in with the leap, cone, or if it's a invasive macroscopic disease, you can go ahead with, see, in case of visible lesions, a punch biopsy might suffice. Now, see, this was about only a growth that you can see. But staging doesn't depend upon only that. You're just making a diagnosis whether it is this growth is actually what? Is it cervical carcinoma de novo, or is it a carcinoma from the endometrium on the cervix? It's a mix of endometrial carcinoma, or is it cervical carcinoma de novo? That's always a debate. That's always a problem, right? So the growth that you can see on the cervix, whether it is actually cervical carcinoma or a mix from endometrial carcinoma. So for that, you need to take a biopsy, right? And now let's say you've diagnosed that fine, it is squamous cell carcinoma of the cervix. Second step is the staging. How is the staging in cervical carcinoma done? Quickly in your chat box, guys, tell me, how is the cervical carcinoma staging done? What all things are you dependent upon when you're doing and thinking about staging cervical carcinoma? I will be telling you everything about carcinoma staging, guys, and very nice notes I have made for you people so that it sticks onto your mind as much as possible. Tell me, okay, it is clinical agreed. It is radiological agreed. Is there any other modality? So everybody who's saying it's only clinical, they're wrong, because you have also radiological imaging as an adjunct tool to screen, to stage the cervical carcinoma.